Can you hear me?
Yes, we are hearing.
Okay, so that's. Is it time for me to deliver my talk?
Say again, sir.
Is it now?
Hello.
My turn. Is it now my time to deliver my talk?
Yeah, may I interfere? Yes, like I'm Dr. Abhishek Saraf, and I will be, like moderating the session. And before you begin, I will be just giving a brief of you, sir. So computer-assisted surgery is becoming at least an important part of orthopedics forum discussion and most indispensable component of surgical tools. The recent robot war between major in orthopedics shows the direction of orthopedics in general and knee arthroplasty in particularly is heading towards. We can now see long-term results in literature of computer-assisted surgeries. Initially, CAS was considered as marketing tool, but now it is becoming more of a necessity. The whole purpose is accuracy, minimal soft tissue damage, and reproducibility. We are lucky to have Dr. Fredrich Picard from Glasgow, who works in one of the most prestigious institute called Golden Jubilee Hospital. He will be among us, and he will be delivering a talk on the usage of CAS. Thank you, sir. You can continue on now, sir.
Okay. So I can share. Can I share probably my slide? That would be. Can I share? And hopefully it should work. Can you see?
Yeah, we can see your desktop, I guess.
Can you see my slides now?
Yeah. We can see, sir.
Oh, perfect. Okay. So good afternoon, everyone. This is a real pleasure for me to be with you all. I'm sorry I couldn't come. I would have loved to, but I promise I will definitely come to see you. I'd like to thank the team for inviting me, and I'd like to thank Ashish and his program committee for asking me to deliver this talk on computer-assisted orthopedic system, and is it really worth it? As a case study, I'm going to use CAS and total knee replacement because obviously they have been out there for now many years. So here are my disclosures. I have been very fortunate to be part of the design and the development of the technology in 1993, and on what was the great father of the first CT-free navigation system. And I was also part and present on the January 21st, 1997. You see a young picture of me, a picture of a young of me for the first ever knee replacement using computer-assisted technology for total knee replacement. It was in Grenoble in France. And our first results were reported in CORE in 1998. This graph is quite important because it shows you the what we call the normalized publications growth curve from 1990s to 2018, and reveals the visibility of navigation. And you see here the navigation publications increase dramatically from the beginning of the century until 2010. And in the same time, MIS came out, because most of the majors didn't have any computer-assisted system at the time, and really wanted to compete with the navigation. Then came the patient-specific instrumentation, and Ashish explained earlier very well what is the technology. And then now you can attend the new wave of robotic assisted surgery for total knee replacement, but also for hip replacement. And robotic surgery was very early in the development of the technology, because Robodoc was actually the first ever computer-assisted system used for, as you probably remember, femoral reaming in total hip replacements. So what were the evidence in 2007 for navigation and computer-assisted technology? Robert Siston, a good friend of mine, who is a PhD from Stanford and he's a professor in Columbia University, did a very comprehensive review of the literature at the time, which was awarded both by the International Society of Biomechanics and the AB in 2007. And what he showed that at the time, there was no more risk of complications using the technology. It was, the technology can improve the coronal and sagittal alignment. Rotational alignment, we didn't know. It did improve the ligament balance, improve the teaching using the understanding of total knee replacement. The cost was an issue, and they did not have any answers about functional outcome, long-term results, and the differences between systems, because that was quite new. So what are the evidence in 2022? Let me show you this a small emoji symbolizing what I've seen all over these years, over the last 30 years, during my talks about computer-assisted technology. I would say very skeptical phase. I'm calling it yes, but. And so, yes, but the risk and complication. What about the fractures? Well, a very recent paper from 2021 showed that the number of fractures during a total knee replacement using the technology can range from 0.06% to 4.8%. So it does exist, but they listed very carefully what were the problems. They said that transcortical pin trajectory, large pin more than 4 millimeters, diaphyseal fixations, multiple placement attempts, which is probably the worst, and the use of non-self-drilling, non-self-taping pins were the most commonly reported risk factors for pin-related periprosthetic fractures with computer-assisted technology or robotic technology. However, when you look at this very good paper from Kenny Krakow, one of the designers of the Stryker system, in 2017, they only found 2 cases out of 3,100 cases. Yes, but there is more infection. This paper from 2017, published in the Journal of Arthroplasty, showed that actually using navigation and the computer technology, these cases have very low complication rate. What about the readmission rate? This paper from 2021, published in Arthroplasty Today, out of more than 1 million cases, found that actually the use of this technology is associated with lower OR of readmission within 90 days postoperatively. Yes, but there is more bleeding. Well, this paper, again from 2021, showed that out of more than 300,000 conventional total knee replacement and almost 9,000 total knee replacement using the navigations, they found that NAV-TKA were at significantly lower risk of requiring blood loss and blood transfusion, sorry. And the last paper from 2016, in fact, showed that navigation could reduce the hemoglobin blood loss. And in fact, it's not just about the fact that we are using navigation, because the practice has changed, as you know. In our department, we are using tranexamic acid since 2005, and the Enhanced Recovery Program since 2007. And clearly, you can see that the transfusion rate for primary knee replacement went from 5% to less than 0.4%. Yes, but what about the DVTs? Well, it's an interesting point. In 2016, this paper showed that we could reduce the hemoglobin loss and the blood loss, but there was no obvious effect on the DVT-PAs. And in 2021, this paper published in Arthroplasty Today showed that NAV TKA is or was not associated with significantly decreased risk for systematic thromboembolism. In fact, in our department, we are ready to publish a paper that has demonstrated that we can reduce the number of pulmonary embolism, but not DVTs. What about the computer crash? That's true, it does happen, and we are very lucky in our department to have many systems that we can use and swap if needed. What is actually extremely important for all of us is to avoid to see these massive emboli or large round embolus, as you see here indicated by the arrow, in the right atrium of the heart when you use an intramedullary roading. So anything that can avoid intramedullary reaming, roading, can mitigate the postoperative blood loss and the dissipation of marrow emboli. This very interesting paper published in 2018 by Kuo and al. Looked at 44 cases of computer technology versus 53 conventional instrumentations. And they measure all these inflammatory markers, interleukin, TNF, TGF, over 72 hours. And what they found is that using computer technology, they had a lower rate level of inflammatory markers. Certainly because we use less invasive tools such as the intramedullary rods, either in the femur or the tibia or both, and because we can define more clearly the soft tissue balance and release more accurately, then probably that was, and that is one of the reasons of this result. Yes, but what about alignment? Well, we all know years after years and hundreds of publications have shown that navigation and computer-assisted technology reduce the number of outliers with respect to conventional surgery. We can certainly, because this is only a measuring tool, reach the ideal goal we want to reach. Well, and that's probably the reason why that today we are talking about several different type of technique of alignments, such as mechanical alignment or anatomical alignments, kinematic alignments, restricted kinematic alignments. This is because we can actually measure intraoperatively what we are doing. Otherwise, it is still eyeballing surgery. What about the coronal and sagittal alignment? Well, it has been also extensively demonstrated that using the technology, we can reach more accurately and more precisely the postoperative coronal alignment and also sagittal alignment. Overall, when you use computer-assisted technology, you can reduce the outliers by at least half compared to conventional instrumentations, and almost a third and probably more compared to patient-specific instrumentations. All these meta-analysis studies published in 2012 and more recently in 2017 confirmed that. Less than 5% outliers, that's what we found and published in Arthroplasty Today in 2017. And what we found that we had more variation on the femur coronal alignment and only 1% outliers in femoral and tibial rotation. The rotational alignment now. Well, let me show you this paper from Kim, and I'm sure you have encountered this paper, published in 2018, which compared the bilateral total knee replacement using conventional versus computer-assisted technology over 15 years. And he found no difference in rotational alignment of the femoral component. And the only factor which prevented him basically to recommend the widespread of this technology was he had more femoral notching in computer-assisted technology. This study was very interesting, but Kim is a fantastic surgeon because as you see, the survivorship was 99% in both groups at 15 years. So it's always difficult to look at these results. The most recent paper from 2021 looked at 15 studies. It's a meta-analysis on almost 3,000 knee replacements. And what they found is computer technology improved the accuracy of rotational alignment of the base plate, tibial base plate, by decreasing angular deviation. Yes, but what about the balance? This very interesting paper from 2018 compared two groups of patients using major resection technique and gap balancing technique. And what they found is after 5 years, the resultant changes in the joint line was more maintained in the gap balancing technique than the measure resection technique. However, they couldn't find any statistical difference in terms of function or quality of life. So clearly, navigation allows the surgeons to measure more accurately the flexion and extension gaps. These very recent paper from 2020 from Mulaji confirmed that. Another one published in Journal of Arthroplasty from Yoon, who also confirmed that using gap balancing technique, we can improve even the short-term outcome. And another one from Japan, also in 2020, confirmed that using computer technology, it helps to improve the postoperative flexion and extension gap. Yes, but what about the teaching? Well, all the papers, and even the most recent one, confirm that navigation and computer-assisted technology does support the fact that the technology is an efficient tool for both experienced orthopedic surgeons and trainees. Trainees may have a better understanding of the procedure and learn standard techniques with a shorter learning curve. And this is probably due to the immediate feedback of navigation system. The learning curve period, as has been already mentioned earlier, goes between 6 to 30 cases, and it depends obviously what system you are using and whether you are familiar with the technology. For example, people who have used navigation in the past, who are using now robotics, are usually quicker to pick up the technique and the technology. Yes, but it costs a lot of money. That's true, and it was already known in 2007. This fantastic paper from Kevin Boschett, published in GBGS, said that, however, the cost saving of using the technology could be achieved if the added cost of CAS is only 629 or less per operation. So it works certainly for navigation, and there is still work to do for the robot to prove that, because the basic concept is to reduce the long-term revisions. However, Mike Swank already in 2009 showed that we could reduce the cost of combined hospital charges because we could discharge the patients earlier. Yes, but what about the functional results? Well, it is still unsure. In 2013, this paper published in Core by Barak said that it seems that the computer-assisted technology gave good midterm reports on the functional improvements. This great paper from Columbia University showed that actually imageless computer navigation in total knee arthroplasty provides superior short-term functional outcomes at 2 years. It was a meta-analysis out of 1,300 cases for more than 10 different groups. Whereas Kim, as we already mentioned earlier, and this most recent paper from New Zealand did not find any significant improvement in the functional outcomes. But again, we are using prompts and not objective data such as gait analysis data. Yes, but what about the long term? Well, this is a fantastic paper that I'm sure you came up with from Richard Steiger, published in GBGS, and they demonstrated that actually in the National Registry in Australia, patients less than 65 years old had less revision when the patients were performed using the technology compared to conventional instrumentations. And after 15 years, they also confirmed that patients over 65 had less revisions. And overall, they are the numbers. If you use the technology to perform your knee replacement, you can reduce the revision rate by 33% for patients less than 65 years old and reduce by 25% for patients more than 65 years old. So it's that only for that it worth it. Finally, what about the differences between systems? You have all sorts of systems out there, and you have to understand them. And you have to understand the concept and the black box software that the companies are using for you to perform the surgery. So are they image-based, image-free, using optical technology like those we have seen today and yesterday, using electromagnetic technology, accelerometers? Is the technology passive, active? Do you use pins or screws to fix the trackers? Do you use bone morphing or pinpoint registration? Do you use touchscreen, pointer, foot pedal to record and match your data? Do you use measure resection or gap balancing or both? And do you have a software which would allow you to perform the femur first, the tibia first, or the combination? Basically, we are running a postgraduate diploma in the UK, in Glasgow, twice a year to explain all these differences, which could really help the surgeon to understand what is behind the computer-assisted system. So what are the evidence in 2022? There is no more risk and complications using the technology. We still need some data coming from the robots because they are still recent, especially, for example, the robot we have seen today. We still need some data. However, overall, it's a safe technology. It can improve the coronal and sagittal alignment in total knee replacement. It definitely now, it has been confirmed, you can improve the rotational alignment. It helps your ligament balance. It's a fantastic teaching tool. The cost is certainly now good for navigation technology, and there is still some work to do for the robots because they are definitely more costly than the navigation systems or the PSI. We still don't really know about the functional outcomes, even though most of the most recent data seems to confirm that it's improved, at least at a short term, the functional outcome. The long-term results are good, as I already mentioned, and there are differences between systems. So, in conclusion, in the 70s, this gentleman, who was a computer scientist, said, computer science is no more about computers than astronomy is about telescope. We can say exactly the same for computer-assisted technology and in particular navigation. Orthopedic navigation is no more about computers than astronomy is about telescope. So this is a measuring tool. You have to use it well, and you have to make sure to understand exactly what is behind the technology. Overall, what is the most important is it all depends how we use it. Thank you very much for your attention.
Fantastic talk, Dr. Fredrich. We are really thankful, and from the whole team of Anup Master course, which is one of its kind of course in joint replacement surgery, from whole team of AMC, we are thankful to you. And in this era, evidence of 2022, yes, we have now no option rather than adapting technology. And definitely, we can see now lot literature that like technology can benefit in such kind of surgeries. We are really thankful to you. And now may I call upon Dr. R.N. Singh, sir, our patron, our role model, to on stage to felicitate our chairpersons.
I would also like to thank you, Dr. Picard, sir, and thank you for being a part of AMC. I went there
Thank you.
to invite Dr. Picard, sir. He was in the theater, but he called me, and he's here today. So thank you, and regards and wishes to everybody at the Jubilee. Thank you, sir. Anand Shankar will take over.
So coming to